Good morning, everybody. We do apologise for the slight delay in getting kicked off today. We thank you all for joining. I'm pretty sure that we're going to wait a couple more minutes for other people to join. Everyone will be placed on mute as they join us. We'll just give it a few. If we put on the next slide, please. Here's a few tips on how to make the best of this webinar. We're going to use the Q&A function throughout to ask your questions, and do let us know who is on the webinar, where you're from, by introducing yourself in the Q&A. We will one that has signed up today. The presenters will need to say next slide so that we can move the slides on throughout. Okay, I think we're all ready to start. I'm going to hand you over to Cormac to do the introductions. Thank you.
Thank you, Ali. Welcome, everyone. My name is Professor Cormac Ryan. I'm the Professor of Clinical Rehabilitation at Teesside University, and I'm also the Community Pain Champion for the Flippin' Pain campaign. This is the third in a series of change webinars from Connect Health to make and embed transformation in healthcare. And we've nearly 300 people registered, which shows just the level of interest in this topic area and the quality of speakers we have today. Each speaker is going to present for about 7 minutes. There's going to be just enough time for a question or two in between before we move on to the next speaker, and then we'll try and hold all the questions and collate all the questions that come through and ask them at the end of all the speakers. To begin, I'm just quickly going to announce a slight change to our format. So we've had some technical glitches with Professor Lorimer Moseley down in Australia. He couldn't hear us or see us, which, you know, doesn't make for a great talk, unfortunately. We are trying to iron those out, and hopefully Lorimer will be able to join us as we go. However, I'm going to step into that first slot and give a quick overview presentation about the role of sort of public understanding of pain and how we need to address it using sort of more sort of public health strategies. So without sort of further ado, I'm going to move on these slides if I can. Oh, can I move on to the next slide, please? There we are. Okay, so as I say, I'm going to introduce each of our presenters one at a time and then move on from there. Next slide, please. Okay, so pain obviously is an enormous problem. A staggering 28 million people in the UK are affected by persistent pain. It affects 30 to 50% of the UK population, and it accounts for almost 30% of the disability. So it is a major issue, and those are in sort of the best of times. Obviously, we're not necessarily in the best of times. This is the time of COVID, and COVID is having an enormous impact on everybody's life, but it will be having a special effect on persistent pain. There was a recent survey of 500 workers by the Institute of Employment Studies, and it found that there has been a significant increase in musculoskeletal complaints. More than half of the survey respondents noted a new musculoskeletal complaint since the start of the lockdown, especially in the back, neck and shoulders, compared to their normal sort of physical selves. And on top of that, it also noted an increased levels of stress, increased feelings of isolation, and reduced physical activity levels. That's kind of a perfect storm in terms of persistent pain for its development and its maintenance. So now more than ever, we really need to think about how we should be tackling persistent pain on a sort of a widespread public health type scale. And that's kind of what the first talk is going to be about. So this is where I would have introduced Lorimer Moseley. So instead, I'm just going to introduce myself. So I've already introduced myself, so obviously I'm not going to do that. But flowing in from what I've just said, Obviously, pain is an enormous problem. And in the past 20 to 30 years, there's been a huge shift in clinical guidelines away from recommending a biomedical approach towards managing persistent pain, away from surgeries and strong pain medications, towards a more biopsychosocial approach, towards more active physical and psychological strategies. Next slide, please. However, that really hasn't happened. In the past 10 to 15 years, actually, we've seen a significant increase in the use of strong pain medications, such as opioids. We've seen a 127% increase in the use of opioids in the past 10 to 15 years. Similarly, in terms of surgeries, if we look at surgery for back pain, we've seen it double in the past 10 to 15 years. Now, unfortunately, that hasn't mirrored an improvement in persistent pain rates. If anything, the prevalence of persistent pain is on the increase. So these strategies clearly aren't working. But why is there this discrepancy between what we're doing in clinical practice and these increased biomedical interventions, in contrast to the clinical guidelines, which recommend reducing them and an increase more sort of active physical and psychological strategies? Well, there is no single answer to that question. However, one part of that jigsaw puzzle will be public understanding of persistent pain. Not just, of course, the general public, but within the public, I include in that sort of patients, healthcare professionals, all sort of areas of society, but it is sort of general public that we all fit into. So this is a list of statements that the general public have been asked to see whether they agree with or do not agree with. And as I go through each one, I want you to think, what percentage of the population do you think would agree with these statements? So if we start off with the first one, it is easy to injure your back. What percentage of the population do you think agreed with that? Can we move the next? Lovely. Almost 90% of the population agreed with the idea that it's easy to injure your back. Next one, if you have back pain, you should avoid exercise. What percentage of the population agreed with that? We remove the cover. 25%, a quarter of people think exercise is bad for back pain. Next one, if you have back pain, you rest until it gets better. We remove the slide. Almost 1 in 5 people, just over 1 in 5 people, again, agree that rest is better for back pain. Next one, bed rest is the mainstay of therapy. If we move the slide, 1 in 3 people agree with that. Next one, everyone with back pain should have a spine x-ray or imaging test. How many? Almost a half of people agree with that. Next one, back pain indicates the presence of organic injury or serious disease. What percentage of the population agreed with that? 50%. And finally, if your back hurts, you should take it easy until the pain goes away. What percentage of the population agrees with that? 2/3. So these figures really demonstrate that within the public understanding, there are a lot of myths, misconceptions, and misunderstandings, and a strong biomedical understanding of persistent pain, which we know is not in keeping with modern contemporary understanding of persistent pain. And it is these beliefs which will be one of the barriers to adopting a more biopsychosocially informed approach. Can we go to the next slide, please? These negative beliefs are associated with increased bed rest, increased medication use, reduced work productivity, higher pain levels, reduced recovery, work absence, and greater healthcare seeking. So public belief and understanding of pain is a really important thing. Currently, it's not where it should be, and that is associated with a number of negative consequences. So we need to think about how we can address this. So the Lancet Low Back Pain series called for action in terms of addressing this. And whilst they were focused on back pain, the call itself, I don't think it's unfair to say, could be focused on persistent pain in general. What they've called for is development of interventions to address misconceptions among healthcare professionals, patients, the media, and the general public. Now, a recent systematic review by Arnella Suman has shown that public health interventions have a significant impact on the beliefs and understandings of the general public, shifting them in a positive way. They've looked at 7 different public health campaigns in 7 different countries. The biggest of those was a campaign run in the late 90s by Bookbinder in Australia. It was the biggest budget. It was all singing, all dancing, mass media with public endorsement, with TV, radio, the works. And it had a real significant impact on an array of different outcome measures, reducing claims with respect to back pain and improving beliefs, not just in the public, but also within healthcare professionals. It was an extremely successful campaign, costing millions and millions. Now, the other campaigns were not necessarily quite as successful, but they had much smaller budgets. However, all 7 clearly had an impact on beliefs, shifting them in a positive way. And that's pretty strong evidence to show that a public health strategy can shift beliefs in a positive way and can thus impact upon all these negative consequences. And what role can we now, where can we now take this? So pain science education obviously is something that we're all, or many of us here on this talk, are particularly interested in and passionate about. And it's an approach, for those of you who have never heard of it, it's an educational approach which seeks to change the way that the person understands pain, away from the old biomedical view that hurt means that you have tissue injury, towards a more biopsychosocial view that hurt does not necessarily mean harm, that pain is not a marker of tissue damage, but rather a marker of perceived threat. And there's quite a body of evidence now to show that when used within clinical practice, pain science education can significantly benefit patients and improve their understanding of pain and their pain-related beliefs. If we go to the next slide, please. So this is data from a systematic review published by my group in 2019, led by my PhD student, Jamie Watson. And in this meta-analysis, it was really neatly shown that pain science education can reduce pain-related fear and catastrophizing by clinically relevant amounts. And we believe that this could be transferred into the public health setting, so we get a lot more bang for our buck. There's also data showing that pain science education, when delivered to healthcare professionals and healthcare professional students, that it can also shift beliefs and indeed clinical behaviours in a positive way as well. So there's plenty of scope for using pain science education to shift understanding in patients and healthcare professionals. And all we need to do, I believe, and I think the following talkers will hopefully agree with me, that if we can scale this up and do it on a public health level, we'll have a much greater impact. This is something they're doing down in Australia. So Lorimer obviously is leading the way in terms of the pain revolution and bringing pain science to the masses and putting the knowledge and understanding of pain into those people who can use it the most, the people with pain, the general public. And here in the UK, we're doing Flip and Pain, which obviously Richard is going to talk about at length in the next talk. And that is where I'm going to beautifully segue and stop and line up for Richard to speak. So this is where I ask the speakers some questions, so I could ask myself a question, or I suspect you're sick of listening to me, so I'm going to not do a question and answer for me, save them up towards the end, and I'm simply going to introduce Richard for the next talk. So Richard Pell is the Flip and Pain Campaign Director and Head of NHS Service Development at Connect Health, and he explains how Flip and Pain came about, what it is, and its impact both on patients and the NHS. Over to you, Richard.
Thanks, Cormac. I'm going to go camera off just to avoid any issues with bandwidth. It seems to be working well at the minute, but it wasn't earlier. So I'll just click that bit off. Yeah, so a perfect segue, Cormac. I was worried for a second you're going to steal my thunder and do all of the intro around Flip and Pain, but such is life, and we work so closely together on it on a regular basis. The origins of Flip and Pain, then, I guess, for us date back to sort of middle of 2018. And it kind of came about where 4 CCGs, clinical commissioning groups in Lincolnshire, were looking to recommission to procure a community, holistic, evidence-based, multidisciplinary pain management service in place of something that was really rather different. They were looking to run a procurement to change service provision county-wide. It represented a big change. And looking on from afar, myself and some colleagues at Connect Health, who had aspirations to be that chosen community provider, were pondering what were the big key areas of transformation that needed to take place to get things to where the commissioner wanted them to be, where they should be, and what were the barriers to overcome to enable this to happen. Around about the same time, our Chief Medical Officer, Graham Wilkes, popped into the office, having listened to Lorimer on a BMJ podcast talk about the pain revolution. And I think in Graham's mind, that's where the stars aligned. The reality is it perhaps wasn't quite as romantic and perfect as that, but there certainly was a sort of penny drop moment where I think we had some clarity about how the pieces of the puzzle ought to fit together, at least in theory. So in terms of what was needed, well, it was definitely more than just a drawing of the line in the sand to say there would be an abrupt change and shift in service delivery model for the people in the locality of Lincolnshire. Clearly what was needed was to steal a Lorimerism or a phrase of the pain revolution. It was we needed to change en masse the way people think about, talk about and treat persistent pain, because what's become another catchphrase, without proper understanding, much of the best advice about the best way forward makes no sense at all. And of course, it wasn't just a Lincolnshire specific issue. Arguably, it wasn't even just a pain management service specific issue. It had pretty much universal relevance across healthcare, because what we had seen happen was service design and delivery had over time become significantly out of step with best practice guidance. To varying degrees, the same could be said for clinical practice, and whether it's a cause or effect, patient and public expectations as well were significantly out of sync with what the best evidence and guidance and science was telling us that we should be doing to support them. So we set about creating the campaign to tackle the problem, which we now know as Flip and Pain. Next slide, please, guys. So it really would be remiss to not state clearly that Pain Revolution and the work of Lorimer's team in Australia was and continues to be the primary inspiration for what we're doing and how we're trying to address it. And we're really fortunate to have Lorimer as a support and mentor in everything that we're doing. So what is Flip and Pain then? Well, it's a public health campaign and it has a focus on raising awareness of the problem of persistent pain, but also it's about encouraging and facilitating understanding of persistent pain that aligns with that of contemporary pain science. Or as Cormac said previously, it's about bringing the science of pain to the people, those who need it most. And my little picture of Bridging the Gap is where we're looking to take people, and people in the broadest sense. We're not just talking patients, we're not just talking Joe Public, we're talking commissioners, policymakers, healthcare professionals as well. So I guess to the informed healthcare practitioner or people working in that field, that a lot of you on the call will be, it's about improving health literacy specific to pain and closing the gap between the outdated, commonly held beliefs about pain as a biomedical phenomenon to what we now understand are more complex phenomenon, simultaneously influenced by biological, psychological and social factors. It's not, those of you clinically minded or are familiar with the research, yes, it has pain neuroscience education at its foundations, but the campaign is not delivering pain neuroscience education as an intervention. It's about delivering it as an enabler, a key to unlocking the door to accessing high value care. And as I said, in layman's terms, it's really about bringing the real science of pain to the people, addressing myths, misconceptions and misinformation, putting people back in the driving seat and giving them the control to make confident, informed choices about their healthcare utilisation and more broadly about their lifestyle. I'll skip to the next slide, please. So the key components of the campaign, which is largely the rest of what I'm wanting to talk about in this short slot. The campaign itself has a brand. In coming to the decisions around the brand, we engage with a lot of people with lived experience of persistent pain, people working in that field, people with expertise in PR and marketing, but also people who had no real background or vested interest in persistent pain at all. The sweet spot, not just of everything that comes with the brand, the tone of voice, the website design, the logo, was to be eye-catching and engaging, something that stands out, but also try and make sure we were credible and empathetic and relatable to those with the greatest need for embracing some of the learning of the campaign. In terms of campaign resources, we have the website, which if you haven't visited, I'd love you to check it out and let us know what you think. There's a load of real stories to try and get people to relate to the journey that people have gone on with persistent pain, as well as lots of links and places that they can go to get more help, more understanding, more support. We've got an established and ever-growing team, majority of which are volunteers, and that includes, of course, our appointment of Cormac as our community pain champion. And then yesterday afternoon, we ran the most recent of our public seminars. First one we'd run virtually, called Pain, Do You Get It? The target audience there are generally people who don't have existing expertise or knowledge around pain science, but it's about conveying some of the key messages of the campaign at scale to Joe Public. And then a real key flagship moment that we're still waiting on for the campaign is our community outreach tour, which will comprise of an outreach peloton, a big cycle ride fronted by lots of our ambassadors and our team travelling across Lincolnshire, which remains our pilot site, but plans beyond that are to take things further afield. A brain bus, which is an unashamed theft or borrowing of a concept from the Pain Revolution, which is our interactive experience laboratory on wheels that will travel around ahead of and accompanying the tour. So what was scheduled for July of this year, but owing to COVID has been postponed to the late spring of next year, is to do a 5 to 7 day tour around the county of Lincolnshire, taking a lot of the spectacle, a lot of the awareness raising, a lot of the focus and the delivery of the key messages to those people, to the people that need it and the people in the areas that might not always get the best access to the best quality healthcare. My pointers across the bottom of that slide are the things that underpin everything that we do along the way. So we are continually trying to get that balance between staying as true to we can as the science and the evidence, which we're absolutely committed to, but getting the right blend in what makes things, what maximizes our ability to get mass appeal and to get an awareness shift as well as a reconceptualization en masse. And my last slide, please, guys. So I'm conscious I've gone over time. Is just to reiterate, I guess, the sort of things that we're looking to achieve from the campaign through educating, engaging with and empowering people, people from different sectors of society and with different levels of interest in what we're doing. And I will sign off there and hand back to you, Cormac, I think.
Brilliant, Richard. Thank you very much. Lovely talk. We have time for one very quick question. What do you think has been the biggest challenge to getting Flippin' Pain up and running?
I think the biggest learning piece has been, so we're fairly committed to co-production But I don't just mean co-production in a typical NHS sense of service users and service providers. I think I include, by the nature of this being a campaign, people with expertise in public relations, in marketing, in communications, and the agendas of all of those different co-producers aren't always naturally aligned. What's true in its purest sense from a scientific point of view isn't necessarily the same stuff that will capture you a headline in a local newspaper or get you on a local radio station, which can offer you significant reach. And there's plenty of damning stats out there that you'll be aware of, Cormac, about how few people actually read literature or publications after the effort that's gone into getting them published. So it's finding that blend between the two, I guess, is a sweet spot that we're going to continue to be looking to achieve.
Excellent. Yeah, no, I having seen you sort of manage that process, it's like herding cats, but you do a great job. Thanks very much, Richard. Excellent talk once again. Okay, on to our next speaker. So we've got Nikki Jones. Nikki is one of our Flippin' Pain friends. She's a person living with persistent pain, and she's going to tell us about her really remarkable and inspirational pain journey. Over to you, Nikki.
Hi, everybody. Yeah, my name's Nikki. I'm 48. I've lived with pain since I was 16 and fell off a horse. But my big pain journey started on Christmas Eve 2002, when basically someone stuck a cattle prod to the side of my head and never stopped for 16 years. I was pretty quickly diagnosed with trigeminal neuralgia, which is a facial pain condition. And I later developed neurogenic headaches, which were extraordinarily painful and completely incapacitating. But 2 years ago, all that changed. It's hard to fit 16 years into 7 minutes. So to summarize, during my pain journey, I tried all the drugs and I ended up on a very high dose of fentanyl. I tried all the surgeries. I had 3 microvascular decompressions. None worked for very long. And I actually ended up with a motor cortex stimulator on my brain. That sort of gave me about 30% pain reduction, never anymore. And I had several pain revisions, wire revisions, and it actually caused occipital neuralgia. I did do a pain management course in 2005, which was very good, but it was very focused on management, and I was still focused on treatment, and the pain science was very old. It was still pain gate theory, which didn't make much sense to me. It's hard to give an account of the effect of the pain on my life, but I'd been a successful professional living in London. With the pain, I ended up having to move back to Wales with my family. The fear, the depression, the fatigue, the constant fight. It was really hard. Trigeminal neuralgia has triggers, so I couldn't have any wind or rain on my face, so I had to cover my face all the time. I couldn't wash my hair, brush my hair, have my face kissed or touched. I couldn't clean my teeth often or talk. Bright lights, loud noises, all of this just sort of devastated my life. It destroys your dreams, your plans, and you get more and more sensitive and disabled. So 2 years ago, I was hard pushed to even walk a kilometre without enormous pain and fatigue. I fell into a hole. I was incurious. I was drugged up. I was depressed. I was plodding and coping in a rut. I tried to live a good life, but it was still smaller, darker and constrained. Medically, I was shelved after the stim. There was just no more treatment that they could give me. I saw a rehab consultant occasionally. My neurosurgeon just sort of tinkered with the stim and didn't do any more changes and just changed the battery when needed. The GP just churned out the fentanyl. There was never any update on the pain management course. Patients don't get CPD, it appears. I never saw a physio, especially for the facial pain. Then towards 2018, some things fell into place for me. I got an escape medication for the neurogenic headaches, which meant that I could actually go out a bit more. I felt a bit more free. I was able to reduce the fentanyl by 25%, which gave me a bit of life and a bit of oomph back. I still believed it was helping me. As a spoiler, it wasn't. I started ballet lessons. I started using my body for me, just to enjoy my body. And I woke up enough to feel the loss of control and be really frustrated by this. I needed to take some control. I just didn't know how. Then I saw an ad for a pain management program in app form. While I was researching the app, I realized how much pain science had moved on. And I found Lorimer Moseley's videos on YouTube. And I watched all of them again and again. And they made such a massive impact on me. I dove deep. I watched David Butler, Dr. Schubiner, Darnell, Clark, Strax, and a myriad more. I was pretty Catholic in my research and viewing. I did see the source papers, but I was better with video and podcasts. And all of this allowed me to reconceptualize the pain. I could see it as essentially a brain misfunction. The pain was very real, but it was a corrupted pathway, not damage, not harm, not danger. And this dramatically lowered the fear levels for me, and then thus the focus. So understanding the new pain neuroscience gave me the why. It gave me a feeling that I could control this. The app gave me the how. It involved serious brain retraining, a lot of psychological work around emotions, around the past, about how it causes unhelpful patterns in the now, journaling, more education, lots of meditation and mindfulness, finding joy again, curiosity, movement, connection, and many other lifestyle changes. And within a few months, my TN pain levels had plummeted. The neurogenic headaches reduced in frequency, in intensity, and the fatigue improved slowly. So 2 years on, I'd say I'm 99% pain-free. I do get the occasional flares, but they're actually very easy to ignore. But you can't underestimate the hard work this has taken. The app program took several months and took courage, commitment, honesty, determination, and a lot of perseverance. And all of this was completely unsupported by anybody medical. And then after that came the graded exposure and the reconditioning of my body, which after 16 years was struggling. I did ballet, walking, yoga, lots of land maintenance on the small holding here, and more lately, cycling. I went from 5 kilometers at the start of lockdown to 30 kilometers now, and it's awesome. Trigeminal neuralgia has many triggers of the pain, as I mentioned. So I actually managed to use my understanding of horse and animal behavior training to decondition all of those triggers. I used graded exposure with positive reinforcement and lots of safety in me self-talk. So due to that process, I can now cycle in the wind with nothing on my face, on top of mountains where the wind is really strong. I talk a lot and a lot. I shower a lot. Previously, I hadn't had a shower for 16 years. I did wash, I have to say. When there's not COVID, I do go to gigs now. I socialise, I swim. I've even been surfing. I have a fringe, which was once impossible. And I clean my teeth with an electric toothbrush. I live. But this is a lifestyle, this self-management. It's not a one-off. It's something I do every day. I hope in the future I have to devote less time to it, but in the last 2 years have been challenging because I've also been trying to taper off the fentanyl during that time. And that's been extremely challenging with some lack of support, including at one point a reinstatement to a dose that was quite high. But I'm doing really well now and I hope to continue that. And I'm really passionate to tell my story to other people to show that this is possible and that by reconceptualizing your pain, your understanding of pain, it can really, really change your life. Thank you.
Wonderful, Nikki. What an excellent, excellent talk. Really fascinating, really, really inspirational. I'm going to ask you one quick question, if that's okay. Obviously, you talked about finding Pain Science and finding Lorimer's talks on YouTube as a useful catalyst to help you sort of turn things around. Do you think if you found these things earlier in your journey, they might have been more useful at that earlier stage or not?
I'd like to say yes, but how do you know? I think if I'd had that information in that 2005 pain management course, it would have made a lot more sense to me. I really struggled with the pain gate theory, because what's the use of a pain gate in my spine when the pain's in my face? It just made no sense to me. So I'd like to think that yes, it would have made a massive difference to me then, but you can't say for sure. And later I was so incurious. I'd been told by so many people that this was it, you know, there was no hope, that I stopped looking. So, you know, having this kind of science in the public domain, much more front facing, I think is absolutely awesome. Really important.
Brilliant. Nikki, thank you so much. Once again, an excellent, excellent and inspirational talk. Okay, so we have overcome our technical issues, and happily we've got Lorimer joining us from Australia. I'm going to briefly introduce him. So he's one of the world's leading pain scientists. He's recently been made an Officer of the Order of Australia for distinguished service to medical research and science communication, to education, to the study of pain and its management, and to physiotherapy. Over to you, Lorimer. Hopefully. Are you there, Lorimer?
Okay, am I audible?
Yes, you are.
Am I visible? Am I visible?
No, you're not, but that's okay. Oh, there you are now. Wonderful. Carry on.
Hey, cool. Well, first I'd like to apologise to everyone for the technical problems. I think it might have been my end. I'd like to suggest that it wasn't, but I think it might have been. But I was able to listen to what you were saying, Cormac, in filling in, and I thought you just did a terrific job. And I really only have a couple of really reflections that I had while you were talking, and then again while you were talking, Nikki. That's just yours is such a powerful story, and I love that you were reeling off all the descriptors of the reality of that journey of having to be courageous and patient and persistent, and I think that remains a real challenge. But how do we get better as health professionals at getting across this message, because I think it is truly exciting, and the best data that we have suggests that when we are effective educators about this, people have truly remarkable outcomes. And I would, listening to your story, I'm thinking, yeah, that's an extraordinary story. Trigeminal neuralgia, with the management strategies that you had in place and the impact on your life, and then did I work out it was about 2 years later, I think, or maybe it's a bit longer than that from when this part of your journey started, but nonetheless, even a decade later, extraordinary. And I think stories like yours should excite us as a healthcare community, and we should be thinking more about who recovers. And the work that we've been doing in this pain education and empowerment and re-engagement space over the last 5 years has been really focusing on recoverers, and what do they think has been important in their journey. And Nikki, you just saved my contributions to that, because the things that our research is telling us, with numbers in the hundreds, are matching exactly what you said. It takes a journey, it takes a shift in mindset, but the fundamental and critical trigger of that shift in trajectory towards recovery is reconceptualizing pain into a protective buffer that's being created by the most amazing, sophisticated and complex protection evaluation system known to humankind. And Lisa, you mentioned, Cormac, a few of the population level educational campaigns that leave us excited that we can make a shift. That research is quite old now. It's 15 years ago, and my understanding, the original pain science education studies are 20 years old, and my understanding of how do we promote learning has changed so much in the last 5 or 6 years, let alone the last 20. That leaves me way more excited about what might actually happen if we do this well. So the couple of specific reflections that you've already touched on, Cormac, and I'll try and be quick in touching on them, is this recognition internationally that the best treatments we have for preventing and overcoming persistent pain are centred around education for empowerment and decision making on behalf of patients, understanding their situation, active and psychological therapies and self-management skills, which, as Richard pointed out, make absolutely no sense if you still think about pain the way we did 30 years ago. The problem is that thinking about pain in a contemporary way is really difficult to do. So we know that outcomes are better if people can flip their understanding. The challenge is now on us as a healthcare community to spread the hope and possibility that lies within the true complexity of pain as a protective experience. And I think we're moving in that direction, and something like Flipping Pain is such a great initiative, I think, because it's not, no one I'm hearing in the space is saying, yeah, this is going to be easy. But everyone I'm hearing in the space is saying, slowly, we can make a real difference here to consumer outcomes. And I think that has to be our goal. In Australia, the Pain Revolution stuff that Richard very kindly mentioned and was very generous about, we're engaging with the same challenges as well. How do we do this better? But we're spending a lot of time excited about what contemporary learning theory is saying might be possible. And we're now integrating that into every aspect of what we're doing. We're evaluating it, and yeah, it's for the first time in my 20 years of being, I guess, at on the edges of pain science developments and pain science education, I'm truly excited about the possible outcomes and the outcomes that actually are emerging. Anyway, aside from that, all of my points were covered by you, Nikki, by you, Cormac, and one by Richard. So I feel quite redundant, and I don't feel quite as bad about being such a technological doofus as I have been. Back to you, Cormac.
Thanks, Lorimer. From one technological doofus to another, I feel your pain. Don't worry about it at all. I'm going to ask you one quick question, and instead of asking a question, I'm going to ask for a quick anecdote. You describe a sort of a eureka moment when you decided to do Pain Revolution. I've heard you mention it before, a moment on a train. Would you mind giving us a 1-2 minute snippet of that before we move on to Deepak?
Well, I hope I'm thinking about the same one as you are, but the moment I recall was in a conference. I was in a pain conference, and I looked around me and I recognised a lot of people, and the research being presented was good research, making increments. But it really struck me. We know enough now to actually go and share that and see lives change. And I remember being so immersed in this, striking me enough that I actually accidentally said this out loud, enough. And the person in front of me turned around and said, enough what? And I replied with, enough talking, let's go and do it. Let's go out there and do it. There is enough excellent science, evidence-based, the incredible bioplasticity that says recover, the irresistible drive to adapt and to recover. Let's go out there and put this in the hands of the people for whom it will transform their lives. We have that obligation, and I think we have that opportunity. I hope it's the same eureka moment. It's the main one I remember.
Yes, absolutely. It's that eureka moment. Whenever I hear that talk, I'm always reminded of a similar eureka moment in myself, which perhaps sums up our two personalities, whereas yours is so almost road to Damascus, you know, inspirational, beautiful. I also found myself on a train. I was on my way to a Flip and Pain event, and I found myself thinking, it's astounding, and time is fleeting. And I became consciously aware that I was singing the Time Warp from the Rocky Horror Picture Show, which was essentially was saying the same thing. We don't have a lot of time. We need to start putting these things into practice. But I just looked like an idiot on a train, whereas you look all inspirational and cool. Nonetheless, I'm going to move on to our final speaker, who's been wonderfully patient. So we have Dr. Deepak Ravindran. So Deepak is a consultant in pain medicine at the Royal Berkshire NHS Foundation Trust and IPAS. Deepak's going to talk about changing the mindset of trauma-informed pain practice. Over to you, Deepak.
Good morning. Can everybody hear me?
Yep.
Brilliant. Excellent. Well, thank you so much, Cormac, for the introduction. And it's been one of my dreams to have a panel of me and Lorimer next to each other. So this has been satisfied this morning. So thank you for the opportunity to talk about what I feel should be an implementation way of bringing together everything that Nikki and Richard and Cormac you've been doing into some form of clinically meaningful way. So I'm a secondary care consultant. I'd like to think a slightly more enlightened secondary care consultant than perceptions may be. I also work in the community within the Connect equivalent in Berkshire called the Integrated Pain and Spinal Service. Next slide, please. And next one after this there. And to me, nothing changes it more clearly as a game changer in terms of my clinical practice than the case of someone we shall call Debbie. Now, Debbie's been there in the pain service up for almost 8 years now. She's been referred from a GP for what started out as a back pain, a chronic low back pain after a work-related injury there. And she had an MRI scan done pretty early on in her phase and had an L4-5 disc bulge, which was attributed to be the cause of the problem. Over the last, she had 3 bundles of notes when I got my Eureka movement in 2016. And at that point, I noticed that she's been having physiotherapy sessions like the NHS does, 3 or 4 sessions every year or thereabouts. She's been having frequent visits to the GP. She's been having referrals to multiple specialties in the hospital there. She's been in the pain clinic for almost about last 4 or 5 years on different occasions for a few of her orthopedic problems, which I'll talk about. And then she is in effect in my care itself. She's been about 8 times in those 3 years that I was looking after her. Prior to that, she was seeing a few of my other colleagues. She's had facet joint injunctions for back pain. She had an epidural after a surgery. We sent her off for a spinal cord stimulator to London. That didn't go very well. And meanwhile, she'd been to neurology. They'd given her a diagnosis of atypical migraine. She'd been to gastroenterology, had a diagnosis of IBS, had a bladder pain syndrome diagnosed from the urologist. Next click, please. And with orthopedics, she first had a left L4-5 discectomy in 2012. This was followed by a left-sided uni knee replacement in 2013. She had shoulder problems on the left side, so she had a shoulder decompression in 2015. Next click. And meanwhile, her right shoulder was giving a problem. She had 1 knee arthroscopy on her right knee and was awaiting a hip arthroscopy at the same time. By this time, she'd been diagnosed with anxiety and depression from the mental health and IAP services, done some talking therapies, been invited for the pain management program with us once before, but didn't engage fully. And the rheumatologist finally diagnosed her as fibromyalgia, and parallelly she had an increased BMI, diabetic, hypertensive. By this time she was on all antineuropathics, on multiple opioids, strong opioids as well. And I was wondering, what do I do? And I was finding that patients like Debbie were present and coming for surgery in hospital, were present in the community when I did my community pain clinics. GPs were asking me what should be the next step there. And in my pain clinic, they were coming along, not responding to injections. And you may all be having such Debbies in your clinical practice, in the community, in primary and secondary care. And the question for me was, well, what is happening? Where is the gap in all of this? And that's what led me back, just like Nikki, became extremely important for me to actually understand what was the reason, what am I missing? Next slide. And so what I decided to find was that I had to be the upstreamist, really. I had to really look at what else was going on, what else was out there, what the reading, what did I not do in my pain fellowship in Stanmore and UCL that was not preparing me for looking after patients like Debbie. Next slide. I read extensively. I completely indulged in Lorimer's talks and multiple other pain talks, Contemporary Pain Science. The book by Bessel van der Kolk was a game changer for me, a mind-blowing experience in terms of reading and understanding what's there. And I understood how flawed the Cartesian model was. And I have to understand, next click, that nothing in biology really makes sense except when you look at it in the light of evolution and what pain is as an evolutionary protective mechanism there. Next slide. And what I realized was that 50% of what I studied and probably a lot of what my contemporaries in primary and secondary care studied was wrong. The problem is, click, we don't know. We don't know which 50% is wrong really. But when it comes to pain, it becomes a lot more clearer and we are starting to understand what's wrong and what needs to change. Next one. We now realize that actually nociception, the actual release of chemicals that come out when you have an injurious component somewhere, is only one part of the picture. And when next click. You've got pain, which is a much bigger experience. There may be places where nociception is there, but pain isn't. But predominantly, pain is an experience, an opinion, which you are now realizing that it is a protective response that needs to be there because it's fulfilling a protective response in the brain, what the brain considers as an aversive threat that it needs to protect the organism from. Pain and nociception are not the same. And that was a fundamental insight for me, which is there, which Lorimer's talked about for many years, which is there in all of his books, which is there in multiple conversations, including the new IASP definition, but it just hasn't become commonplace enough. Nociception as a word doesn't exist in normal language, and we need to think about making the distinction clear. Next slide. Because the IASP itself knows that we do not have just nociceptive and neuropathic pains. We have a third category, what's called nociplastic pain. And when I look at my patient clinic profile in my hospital, next slide, I would actually have to say that, next click, is actually that nociplastic pain or centralized pain, where there is a significant change in how the brain and the spinal cord and the nervous system and the nervous and immune system in parallel amplify these responses, is the bigger picture. The nociceptive and the neuropathic components actually reduce and become much more marginal as time goes by. That has an implication. Next click. Because when you come to treatments, the entire biomedical model is geared up for treating nociception. We've got medications which do a decent job. We've got interventions, injections, take your pick, surgeries of every kind that do a decent job when you are absolutely sure that nociception is your only item on the table. But we know, and that's where I think we are all as a biomedical model flowing ourselves, is we don't take into account of what we must provide for pain. But when you look at the bigger picture of pain, we realize it's context dependent. We realize it's lifestyle dependent. We realize that sleep is having a big impact on it. The recent studies show how much psychosocial stressors make an importance there. The upstream effects of deprivation, poverty, bullying, other forms of changes. The microbiome and the gut and how nutritional impacts on the immune system and the nervous system is equally important. And the biggest picture of all is trauma. Trauma in all its forms. The smaller traumas around bullying, violence, road traffic accidents, to an divorce and parental separation, to the big ticket traumas of death or actually adversity in before the age of 18, which has a major impact on how the nervous system and the immune system develop. My personal feeling from the reading of the literature, and I can go on for hours on this, next click, is that when you have a significant adversity in your childhood especially, but that can happen even in your late teens or 20s, and you have limited support or resilience from society or your immediate loved dear ones or isolation in this case in time, you can have multiple fallouts. Each of these systems that you see around you, whether it's the nervous system, whether it's your amygdala and your brain development, whether it's your endocrine dysfunction or immune dysfunction, they will all result in cascade and could potentially, now the studies show that they cascade into the conditions that now populate what healthcare is facing as a crisis of how to manage. Where is the common link? Next slide. So my suggestion would be that this is the time to be actually looking at our pain practices and be more trauma informed, to actually step one, look back and look at our patients and say, not why are you like this or what's happening or why are you not taking your drugs or why are you on more opioids, just to say what happened to you, what changed, what are the problems, what are the issues, and to actually enable system-wide thinking to know our patients much more holistically. Because once you know that if someone is having limited support or high traumatic experiences, or there is an influence of psychosocial, that will make us cautious or should make us cautious about how we're going to order investigations, how much we want to medicalize something, how careful should we about opioids, and specifically about the role of interventions across primary, across secondary and community care. And these interventions can be anything, could be even pain management programs. We need to ask that question. Next click. And so therefore, significance for health systems is preoperatively, we need to know how to optimize these patients properly. Postoperatively, there is this risk of dependence, and these are your high frequency flyers, and it makes a difference in how we implement other treatments. Next click. And I will end with this point here, that if we want to have an integrated service that gives hope and recovery for patients across primary, secondary and community care, we need something like Flippin' Pain and these campaigns to reinforce the neuroscience in an empathetic manner. We need to have a service that across the board, through health coaches, through social prescribing, through PCNs, through community care, focuses on diet, sleep, physical activity, and all mind-body therapies in what I kind of call sort of the mindset change that has to happen across systems, and a more trauma-informed pain practice is what I feel we should all be embracing across the horizons. And I think that's where I will end. Thank you so much, Cormac.
Excellent. Thank you, Deepak. A lovely talk. Really clear. I'm going to open up to the question and answer panel now, but I'm going to bring us first back to your talk, Deepak, and throw a question towards you. Within the Flippin' Pain campaign, obviously one of our aims is to change the way people think about, talk about and treat persistent pain. And I think it's aimed at the public at large, but to sort of achieve those aims, healthcare professionals are so crucial to bring with us. How can we engage with healthcare professionals as part of the campaign to bring them on board to help change sort of public understanding of pain? What should we do to bring healthcare professionals with us?
It's a very good question, Cormac, and it's something that what Richard has been doing and trying along with you is I think the first and the best way to take this forward amongst the public, and then use the same conversational pieces for healthcare. Like Lorimer, I have been quite interested as well in seeing what exactly is missing in our healthcare professionals' lexicon. And I do think that they are all so good in their niches there. Sometimes we need to kind of use the same language that we're using here for our patients to actually say that this is what needs to change first, our understanding of what we are doing for the patient. And if we can align it for the patient, then I have found that conversations in my local patch have become a lot easier to get some treatments. This establishment of our community service was also made possible by just saying, what can we do best for patients, and say, this is what we want to provide holistically. That made it easy for healthcare professionals, for GPs and for spinal consultants and some of my colleagues to say, fine, okay, we will accept that this is the first step, and that would be there. I think it is a small process to be done in small steps and iteratively improve as we go along.
Wonderful. Thank you, Deepak. Lovely. OK, so I'm going to try and feedback some of the questions that we've had as we've gone along. I'm a complete technophobe, as I've already mentioned, so I will do my best. Bear with me. OK, so here's a question from Chris. How do you think we might meet the need for ongoing support in their self-management journeys within pain management services, which currently work to a very short-term model? I'm going to direct that to Lorimer. Lorimer, would you mind having a go at that question?
Yeah, I could have a go at that question. I wonder if I'm not best placed just because I work in Australia and I'm more familiar with our context. But I actually think it's a really astute question, because it feels odd, doesn't it, for pain management services to be short interactions, because most people have a long journey. The way that we are trying to engage in that is to shift more of these sort of health coaching type roles into primary care and even into community roles. So we're currently engaged with the possibility that recovered patients can take on roles of ongoing coach through that journey. They certainly have expertise that people who haven't been through the journey don't have. And if they have been through that journey, they often have the scientific expertise as well, because they've managed to get a handle on that, and they have great credibility. So we're trying to deal with that by shifting things into primary care contexts, but I don't think we've really solved that problem. I'd be very interested to see what options people in the UK think there are there.
Absolutely. I'm going to move over to Nikki and ask her to follow on with that question, if we can, in terms of self-management within the UK and encouraging self-management. What support have you had, Nikki, in terms of supporting your journey from a self-management perspective, and what do you think needs to happen? What would happen in a perfect world from a self-management perspective?
I've had no help, none. It's always been biomedical, it's always been intervention. Nobody's ever really talked about self-management at all. There was the program, but that was just pacing really, and you slip slide. So no, but I was really pleased to hear Lorimer say about pain, peer coaching, because I really strongly think that that's where it is. I'd love to do something like that myself. I know a lot of amazing pain people who are living with pain who could do that role. There's so many of us out there, and we're a really valuable resource that just isn't being tapped into. And I think we should be. But I do think it should be a paid role. I mean, it should be a respected role as part of a multidisciplinary team. And I think that self-management really should be sold as supported self-management. I don't think it should be, as it is too often seen now, it's the last port of call. It's the, we don't know what to do with you, you go off and self-manage, and it feels like an abandonment. And it should be brought in much sooner, and it should be supported by all healthcare professionals and by peer coaches, and that would really help people.
Yeah, that's a really fascinating approach there, Nikki. The idea of bringing in sort of peer coaching, I think is a wonderful idea, but the idea of paying them, I think that's a wonderful, wonderful idea. What do you think would be the response of sort of expert people with pain per se? Do you think if we began to advertise such roles that people would apply for them?
Well, I can think of about 10 people off the top of my head who would be applying for those roles just on our little niche of Twitter. So yes, not everybody's going to be suitable, not everybody's going to want to do it, but I know a lot of people who would be absolutely incredible at such a role.
Absolutely. Wonderful. Thank you. So thank you very much. I think that's certainly something that needs to be looked at from a research perspective. I think there's an awful lot of mileage in an approach such as that. Okay, so bear with me while I look through my questions, and I'm going to go back to Lorimer. I'm going to ask a question about how do we address the lack of understanding of pain around the world? What efforts have been proven to change and drive health literacy in this area?
I love that those questions come in, and I think we've got about 4 minutes to go, or something. But
no rush, take your time.
Yeah. Well, a lot of efforts are being made internationally to improve all of our understanding of pain from the community level up. And some of the people on the call will know that one of the rants that I often go on is that we need whole of community education. And the ways to do that will depend on which part of the community we are engaging with. I mean, really it's about resources, I guess. How do we present information that is at once very challenging, but also very hopeful and exciting amidst a context or within a context where there are definitely stakeholders in maintaining the status quo, and I think relevant to that is the very first question that I think you might have put to Deepak Cormack about how do we bring health professionals along on this journey. And if we thought about that from how do we bring physios along, how do we bring nurses along, psychologists along, medically trained people along, consumers along, I think the consistent theme across those groups is with respect and with compassion for the difficulty of that journey. I mean, some of us might feel like we've made that journey, or we're at different places on it, and we forget how hard it was to make that transition. So I think the mechanisms by which we can promote health literacy need to be informed by the learners, and we can do better at that. I think that if we're wanting to improve consumer health literacy, we should have consumers in the middle of that plan. And if it's health professionals, we should have the health professionals who are at an earlier stage of their journey participating in development of those strategies. But in short, lots of techniques, lots of strategies, policy level, lobby your politicians, get on the local radio, but I guess do it with this constant reminder of this is only going to work if we stay mates, and we can only stay mates if we stay respectful of where we all are on that place.
Absolutely. A really good point. Thank you. I've got 1 more minute, and I'm going to bang this back over to Nikki. Nikki, in terms of health literacy, I'm really fascinated how you went from taking a quick look at a bit of pacing to someone who really has a really high level of knowledge and understanding around persistent pain. How did you get from A to B?
Well, I mean, I do have a science background. I did, environmental science as a degree and part of a PhD. And I'd done a lot of, I really focused my sort of intellectual capabilities on horse training, which is obviously very science-based, learning theory and conditioning, etc. So it confuses me that I wasn't actually interested in it. But once I was interested in it, it was so fascinating. It was actually really easy. And there's a lot of such accessible neuroscience out there, like Lorimer's videos are just so accessible for everybody and make it really easy to understand. And from then on, it's just easy to, carry on and keep learning and learning and learning. And, there's a lot out there, and I know a lot of people who are really interested in it and find it fascinating. So that's really good. So it just needs to be a bit more widely known.
Absolutely, I agree. I think lots of people with pain would like to know more, but they're not necessarily given the opportunity or given the access to the best information. And I think that's what the Flippin' Pain campaign is all about. I know it's what the Pain Revolution is all about in Australia, and I think we can all do these things better and make a real difference. Guys, we're already a minute over time, so I'm going to sort of wrap up by saying by asking us to move on to the next slide, if we can, please. I've just got a little message here. Don't forget. I've just got a message from the person organizing the event saying don't forget the slide. So let's not forget the slide. Here we go. So there are some upcoming events from the Connect Health Change program. So on Wednesday, the 11th of November at 12:30, we've got a COVID rehab focused event. On Wednesday, the 18th of November at 12:30, there's an AI triage focused event. And finally, there's an improving access to psychological therapies event on Wednesday, the 2nd of December at 12:30. You can sign up here. Looking forward to seeing you all there. It just the last thing I'd like to say is thank you to all of our speakers. A really, really excellent set of speakers, excellent set of talks. Thank you all for joining us wherever you're listening from your homes, from work, from the car park at Tesco's, wherever you are. You're very we thank you for joining us, and take care. Bye bye.